Good morning. This is Dr. Garais, and this is the box representation or diagram of that can help you with the internal and external anatomy of the heart, and it also can help you with um, the flow of blood or the cardiac cycle. So let's begin. Let's start off. The box is the heart is essentially a box, okay, and it is a box created by 4 chambers or 4 rooms. Wait a minute, eraser. Okay. Maybe squiggy. All right. Okay. In a moment, I'm trying to do this without erasing things. So essentially, the heart is separated into right and left, and this is the left side because remember, you're looking at the heart at the perspective of your patient and not your perspective. So your right is your patient's left. So this is the right side, left side of the heart, left, and this is the right side of the heart. These are the upper chambers, which are much smaller than the larger chambers below, and the upper chambers are your atria, and your lower chambers are your ventricles. Now, when you look at this diagram, let's now change colors. Everything on the left side of the diagram, and I'm going to label this left, all the red blood cells, or most of the red blood cells, not all, carry oxygen. Therefore, anything on this side of the diagram is oxygenated. Okay? So, when you're looking on everything on the other side or the right side, R for right, the red blood cell is deoxygenated. Okay? So let's go through the cardiac cycle, and of course, and we talked about this is atria, the small ones, and the big ones are ventricles. So this has to be the right atrium, and that's deoxygenated blood. Blood goes then down to the right ventricle, and the deoxygenated blood, meaning to say, is the majority of the blood on the right side of the heart is carbon dioxide. And the right side, right, and this is RBC. Let me try to make this a little bit better, R. And this RBC, red blood cell, right, this is your pulmonary circulation, because we're going to be going back to the lungs. And this is your systemic circulation, because we're going to supply the rest of your body or the rest of the systems with oxygen. And of course, if that's the right atrium, that's the right ventricle, this has to be the left atrium, and this has to be the left ventricle. Okay, so how do it goes? That alone will help you identify both internal and external structures, and I'll show you in a moment when we look at the heart, the actual diagram. So let's now go through the cardiac cycle. The cardiac cycle is a trace of a single drop of blood from your left atrium all the way through the cycle. So the way the cycle works is it starts and ends in the same place. So we're going to start at the left atrium and we're going to end at the left atrium. So let's begin. So left atrium, blood will go down, and in a cycle, blood only goes one way. It doesn't go backwards. And if it goes backwards, we got a whole bunch of problems. So left atrium, blood goes down to the left ventricle. Now it passes through a set of doors. And you could see I drew one door here, one door there, so that's two doors. And if you recall your medical terminology, bi means two. So cusp means a leaf or a door, leaflet or a door. So this AV valve or atrioventricular valve has two doors. Therefore, we called it bicuspid. Bid. Now, bi, two, and since it's got two doors, it also has two names. It's also called your mitral valve. Now, from the left atrium goes into the larger room here, or chamber of the heart. That's your left ventricle. And it goes through a semicircular or semilunar valve, not circular. Now, if there's a semilunar valve on this side, there's also a semilunar valve on the other side. Just keep that as a mental note there. Now, the blood goes through the left ventricle, through this semilunar valve into a very large artery, the largest artery in your body, and that artery is called your aorta. And of course, your aorta, right? Then if that semilunar valve goes through the aorta, then that semilunar valve has to be called the aortic semilunar valve. Makes sense. And then of course the aorta and through all the other arteries brings oxygen to the rest of the system, hence the systemic circulation. So to recap on this side thus far, from the left atrium, goes through the bicuspid, also known as your mitral valve, and that's an AV valve, an atrioventricular valve, then into the left ventricle through your aortic semilunar valve, then through your aorta, and then out. You could see how if you wrote that out in just letters, which most textbooks try to do, like in some sort of, in a similar way that you guys do your concept maps, you could see how it would kind of be difficult to remember. But if you look at this, take a few seconds to really look at this picture, even though it's not the neatest picture in the world, you can close your eyes and kind of see it. You see red, you see two doors, you see an arrow going down, you see an LA, LV, and then a big fat red artery, aorta, right? And those arteries are typically colored red in textbooks to denote that that particular vessel or tube is oxygenated. So once we go through the entire system, what happens? Your body uses up all the oxygen, and what does it throw out as a waste product? They throw out carbon dioxide. Okay, so once it throws out carbon dioxide, it comes back to the heart into two tubes. Everything from your head goes through one tube called your superior vena cava. And that makes sense. Superior means up, right? Vena means vein, cava means, big cave, a big tube. That makes sense. And everything from the rest of your body or your trunk, that goes into another tube called your IVC, inferior vena cava. Both the superior vena cava and inferior vena cava is colored blue in my diagram here. And then it just falls into the right atrium. And then it's going to go through three doors. 1, 2, 3. And from the right atrium, it's going to go down through these 3 doors, right ventricle. And lo and behold, if this side's called the bicuspid, this side has 3 doors, that has to be called the tricuspid. So you have your bicuspid over here, your tricuspid over here. Then the right ventricle, and what we also mentioned earlier, that there's another semilunar valve here. And that semilunar valve is going to be, since it's the pulmonary cycle, it's going to be heading out in this artery here to the lung. Hence pulmonary circulation. And this is, if the aorta is an artery going away from the heart, this is also an artery going away from the heart. Hence, this is the pulmonary artery. From the pulmonary artery, it goes to your lungs. And what happens in your lungs? You exhale carbon dioxide, and then you inhale oxygen. Uh-oh. Let's erase this. All right. So lungs. And just to recap, the lungs will pick up oxygen. And of course, a vessel going back to your heart is a vein. So the lungs are going to bring oxygen. If this is the pulmonary artery, this has to be the pulmonary vein. And we ended up right back where we started. Okay? So how is this beneficial to you as the student trying to learn this stuff? Well, now you know your right from your left. You now can answer questions of which is oxygenated or which is deoxygenated. So example, I could ask you, the blood in the left ventricle, is it oxygenated or deoxygenated? Does it have a majority of oxygen or a majority of carbon dioxide? And you'll tell me, oh, it's red. It's on the left side. It's part of my systemic circulation. Oh, then it's got to be oxygenated. The right atrium, is it oxygenated or deoxygenated? And I just look in my mind's eye. It goes, it's blue, and it's on the right side. I could ask the right ventricle, is it part of the pulmonary circulation or the systemic circulation? And you'll tell me pulmonary circulation. The pulmonary artery, is it oxygenated or deoxygenated? And you'll see it's what? Deoxygenated. Now, the pulmonary artery and the pulmonary vein are exceptions to the typical rule that any blood vessel or tubing going away from the heart is an artery, and it's usually oxygenated. But the pulmonary artery is a tubing going away from your heart that's deoxygenated. And the pulmonary veins are typically deoxygenated. The pulmonary vein is oxygenated. And then you can easily see the close relationship between the heart and the lungs. If we look on the right side of the heart, there's something called cor pulmonale, C-O-R-P-U-L-M-O-N-E. You could look that up. Also known as right-sided heart failure or congestive heart failure. It is when there is backup pressure from the lungs, and look what happens. It's going to make, that backup pressure is going to make the right ventricle work harder. And if the right ventricle works harder, then the right ventricle, since the heart is a muscle, is going to grow. And if it grows out of control. That's called right ventricular hypertrophy, if you recall your medical terminology, and that's not good. Your patient will not only have pulmonary symptoms, they'll also have cardiac problems. Another thing that we also have to recognize is if the blood pressure against the aorta, which is our blood pressure, right? And in hypertension, it can be high. It'll back up pressure all the way to the left ventricle. The left ventricle will work too hard, and then the left ventricle will be hypertrophied. And then you get left ventricular hypertrophy. You can now see on both EKG and you could see on an EKG left axis deviation, meaning all the electricity is moving towards the left ventricle of the heart. and that's not good. It means the heart's working too hard. Now in cor pulmonale, you'll have right ventricular hypertrophy, also known as right axis deviation, and that's when all the electricity is starting to move towards the right ventricle. So either situation is not good, and you could see how you look at the box diagram, and it seems very clear on why this happens pathophysiologically. Another thing, kind of question I could ask on the final is, which came first, where it goes, and this is a cycle. So I could ask you, where does the blood go from the lungs? And you'll tell me, oh, pulmonary vein into my left atrium. Okay. My patient has tricuspid atresia. That means blood goes, blood's leaking out where it shouldn't be leaking out. Is that the right or left side? You know that the tricuspid is on the right side. So in a way, you just answered a medical school question. What kind of murmurs are you going to hear on tricuspid atresia? You're going to hear it on the right side versus the left. And a murmur is essentially abnormal sounds that these doors make. And where are the doors? You have your tricuspid here, bicuspid here, your pulmonary semilunar valve here, and your aortic semilunar valve here. That's why you have two heart sounds. You have the lub and the dub, and they correspond to the closure of these valves, both the AV valves and the semilunar valves. Now, it becomes pathological or abnormal when the sounds sound weird or different. And it makes sense, because if these doors where blood is going through it don't open and close, they're going to make these extra sounds, just in the same fashion as, you know, your sink that maybe has a bad washer or, you know, a bad faucet. It's going to leak and it's going to sound funny. So that is the box diagram. I tried to redo it this way because my other video is like almost 6 years old and it's not as clear. So my suggestion is to try, you know, get a red and a blue marker and try drawing this on your own a couple of times. First, try to do it by looking at the picture, and then try to do it on your own. And if you could do it on your own, it could answer a whole bunch of problems. So let me now also screenshot this so that you can also have an actual picture and not only a video. Let me take this. All right, now let's look at how it goes. How is this going to relate to the world when you look at things? Let's look at the external structures of a heart and a typical heart. Oh, I hate Pinterest. Why do I always? Now, Quizlet. Can I just have a regular picture? Is it so hard? Internet, thank you. Okay, let's look at this. And you could look at something diagrammatically like this, but typically on your exam, which will be colored, you'll have something like this. Now, this is the anterior view of the heart. How do you know it's the anterior view? Well, first of all, you know it's the anterior view because who do you see up front? You see the two small rooms or chambers, the atria. And remember, we have to look at it at the perspective of our patient. So this side is, of course, right. This side is, of course, left. And this is your interventricular sulcus. So that's a groove in the front, and you'll notice it goes diagonally and off the apex. This is your apex, and all your great vessels here is called the base of your heart. So within the interventricular sulcus, now I know it's going to separate the two ventricles. And now I know from my diagram that this side has to be the left ventricle. This has to be the left atrium. This has to be the right ventricle. This has to be the right atrium. And if you can use your imagination a little, doesn't it make a cross and form a box? Now, you know this is your right ventricle. You know there's a blue tube coming out of your right ventricle. So this has to be the pulmonary artery. There's this big red tube, and you got to use your imagination a little bit, but it's coming from this side. And when in laboratory, remember we stuck our finger down here and it ended up in the left ventricle. So from the left ventricle going up and around to this very, very large aorta, that's how I know that that's the aorta. I'm looking at here, the right atrium. We know there's this big tube coming from the top. So that's got to be your superior vena cava. We also know there's got to be a blue tube coming from the bottom into this right atrium. So that's got to be the inferior vena cava. We look here on the left atrium. I know I have red tubes and I should have two sets of them, one here, and they're going to end up here. And that makes sense because they're going from my lungs. And the red tubes from my lungs to the left atrium have to be the pulmonary vein. So you could see, and another thing you could do is you take this, erase all these, or take a piece of tape and or piece of paper, erase all these. Do you think you can quiz yourself now and until week 9, week 10? If you quiz yourself every other day until week 9, week 10, you'll not only get it right and get easy points on your final, you'll also be able to look at any heart, because whether it has color or not, because in real life, what do? Just as in lab, you feel around for it. Now, another last thing about the anterior view, the interventricular sulcus, again, goes diagonally. And the important part of these arteries and veins here is those are your coronal arteries and veins. Corona or coronary means it's pertaining to the heart, like a crown. So these are very important and they're very small because these are the arteries and veins that will supply your heart, because your heart's a muscle and it needs its own oxygen. Now, what happens in a heart attack, also known as an acute myocardial infarction? Myo means muscle, cardi, heart, infarct. When you have an infarct or a blockage, it's going to block oxygen from getting to a certain part. And you could see the left, this anterior interventricular sulcus houses a very important artery called your left anterior descending artery, right? And also your great cardiac vein as well. If these get blocked, a good chunk of your left ventricle is going to start to die. And we already know from the diagram that is not a good thing, because the left ventricle helps pump out the blood to our systemic circulation. Hence, when you have a myocardial infarction, you're going to get either hypertension or hypotension, but you're going to get some serious problems. And it's also going to look bad on the EKG and also look bad on the sonogram. And then you could look at it and understand it. Oh, that's the left side, and it's going to have systemic circulation problems. Okay. Now let's look at the posterior view of the heart. You could see that I can't see the atria, or the atria, I can see only the back part of the atrium. But you have here the posterior interventricular sulcus, which on lab we saw goes straight down and straight into the apex. And this is how you know you're in the posterior view. Now, when you're taking an exam or you're taking a lab quiz or looking at a specimen, your first thing that you're always going to tell yourself is, what am I looking at? Am I looking at the front or am I looking at the back? So here, I know I'm looking at the back. Now the perspective has changed. My patient now has my back to me. So now this is the left side and this is the right side. So now I know that this has to be the left ventricle, because this is the posterior interventricular sulcus. This is the right ventricle. This has to be the right atrium. This has to be the left atrium. And the right atrium, we have a tube coming from the back or downward part. So that's got to be the inferior vena cava. You have this tube, which is going up from the top into your right atrium. That has to be the superior vena cava. You have this huge artery. That's unmistakably the aorta. And here on my left atrium, I have these 4 red tubes coming from my lungs. So that has to be your left pulmonary veins and your right pulmonary veins. Okay, and it goes, and here, this is your pulmonary artery, goes, which is better seen in the anterior portion. So can you also take this picture, block out all of this and practice it, and also practice from now until, and it just takes 15 minutes. If you can't afford 15 minutes per day per chapter, you should seriously reconsider your time in school and how much time you're spending on school. Cramming will not work. Cramming, you may get a B, heck, maybe even an A minus, but what happens when you go to other classes where you need to know the anatomy, internal and external anatomy of the heart? Now, the heart has layers. And the outer layer that in laboratory that we said got peeled off is your pericardium. Then there are 3 layers within the heart that you can see. There was this really thin, like fat, it's not really fatty, but there's a thin layer of fat. That's your epicardium. How do you know that's on the outside? Because you look at the prefix epi. Your myocardium, which is the chunk of the muscle of the heart, and then you have the endocardium, which is the inside or internal structures of the heart. If you've had a heart attack that's already at the level of the endocardium, like I stated in lab, don't make any plans. You're going to need a new heart. Now, when you look at this madness, or this, let's look at this one. Now, let's look at, is there another better picture? Let's look at this one because it's more diagrammatic. Now, this is the internal structures of the heart, assuming that, and I'll tell you that this is the anterior view. So if this is the anterior view, the left side is over here, and then the right side's over here. Okay? So this is obviously left atrium, left ventricle, but we now know there's a door that goes from the left atrium to left ventricle. So that's got to be the bicuspid, also known as the mitral valve. Okay, I look here on the right side. This is my right atrium and my right ventricle. And this AV valve from my right atrium to my right ventricle, right, has got to be the tricuspid. And I also know from my right atrium, I have my inferior vena cava coming into it, and also my superior vena cava coming into the right atrium. Now, this is where it gets a little bit tricky, but using your box diagram, I know there has to be a tube exiting my left ventricle. And we now know all the tubes exit off the top, not the bottom. But diagrammatically, I have to know that there's a semilunar valve somewhere here that's going to connect into this huge artery, and that's a aorta, right? And same thing with the right ventricle. There's got to be a tube that exits the right ventricle. This has to be the pulmonary semilunar valve, and that's going to exit. It goes, and it's got to go through one lung and the right lung and the left lung. So it's going to have to split off into your right pulmonary artery and your left pulmonary artery. So you could identify this the same way as this. And this is even better because it's color coded. And you could remember and you could see right side blue, left side red. Let's also now look at the internal structures of the heart a little bit closely regarding your atrioventricular valves and those leaflets or the doors. Let me try to find something. Here you go. Here's one's nice. So let's look at here. This is, of course, an AV valve because this is my right atrium and this is my right ventricle. Here's my left atrium, left ventricle. So this has to be my bicuspid. And in this drawing, they purposely drew 2 papillary muscles, 2 sets of chordae tendineae, right? They're, remember what a tendon is? It connects muscle to muscle right here to connective tissue, right? So this is connective tissue. So this is called chordae tendineae. And of course, this is your mitral valve, also known as your bicuspid. And on my exam, what will I do? I'll erase all of these, A, B, C, D, E, F, G. So, and I'll even tell you, anterior view. Or heck, I'll even ask you, is it the anterior view or the posterior view? And you now know that, oh, look, 1, 2, bicuspid. So this has to be left side. So this has to be the anterior view. If you look at here, the artist purposefully drew 3 papillary muscles, 1, 2, 3. And papilla, if you look at the word papillary, it's, look at here, this word papillary, doesn't it look like fingers sticking up? Especially this part, looks like fingers sticking up. And that's what a papillary muscle is. These little fingers connected to the chordae tendineae, connected to the tricuspid valve. You'll also see on laboratory and in this picture, do you see how thin-walled the atria are and how smooth? That means they're under low pressure. Do you see how thick and there's got a lot of like branches and things, thick this wall is on the ventricle because it's under high pressure, okay? So you have low pressures and high pressures. Your heart pumping pressures out into your lungs and your systemic circulation. That high pressure is called your systolic circulation. And your low pressure is your diastolic. So, and that corresponds to when the heart fills up with blood. So when you have a blood pressure of 120/80, which is the typical normal blood pressure for a 70-kilogram male patient, the 120 is talking about millimeters of mercury, is talking about the pressure in your ventricles. And the 80 millimeters of mercury is talking about the blood pressure when your heart is filling with blood, typically within your atria. Okay, and now you can also see where form, which is anatomy, meets function. So, because since this is low pressure, why does this have to be thick-walled? It's thin-walled. Same thing with veins. It goes, look at how fat and chunky the aorta is. Look how fat and chunky these this part of your descending aorta. It's fat, it's thick, it's chunky, and you saw that in lab. But if you look at veins like your superior vena cava and your inferior vena cava, they're thin and they're flat because that's low pressure. And that brings me back to the next topic, is the difference between arteries and veins, which we've kind of been alluding to all throughout this lecture. The difference between arteries and veins is the arteries are under high pressure. They have a thick tunica media, which is a thick middle wall of muscle, which controls blood pressure. But the veins are low pressure, and they're taking blood back to the heart. Now, remember, it's a cardiac cycle, so the veins, the blood only has to go one way. And in the veins, they have these valves to prevent the blood from backflow and going the wrong way. But when you get older and you're like me and you stand around a lot and move around a lot, when we get older, the veins start to fail. And when they fail, the veins get really fat, tortuous, and painful. And that's what we call varicose veins or varicosities. Okay, so that's the internal structure of the heart. Now you know what I could test you on. Now, last but not least, let's talk about the electrical conductivity of the heart. And the best is a video, this really quick EKG video, and I have it here, and I'll share this link as well.
Want to lower your high blood pressure without additional medications?
Yes,
Not
I
possible,
do.
right?
All right.
Well,
let's watch this, and I'll pause it at certain points.
The cardiac conduction system consists of the following components: the sinoatrial node, or SA node, located in the right atrium near the entrance of the superior vena cava. This is the natural pacemaker of the heart. It initiates all heartbeat and determines heart rate. Electrical impulses from the SA node spread throughout both atria and stimulate them to contract. The atrioventricular node, or AV node, located on the other side of the right atrium near the AV valve. The AV node serves as electrical gateway to the ventricles. It delays the passage of electrical impulses to the ventricles.
So the SA node, also known as your pacemaker, the AV node is also known as a gateway. And what does a gateway do? It stops you from going through. AV node is also known as the brakes, BRAKES, of the heart, because there has to be a pause between the contractions of your atrium and your contractions of your ventricle, because it has to allow for the blood to go down, right? So SA node is the pacemaker, and it typically fires around 100 beats per minute, but that's really too fast for us. So the AV node slows it down, okay? And the AV node, so SA node, pacemaker, AV node, the brakes or the gateway for the electrical conduction of your heart.
This delay is to ensure that the atria have ejected all the blood into the ventricles before the ventricles contract. The AV node receives signals from the SA node and passes them onto the atrioventricular bundle, AV bundle, or bundle of His. This bundle is then divided into right and left bundle branches, which conduct the impulses toward the apex of the heart. The signals are then passed onto Purkinje fibers, turning upward and spreading throughout the ventricular myocardium. Electrical activities of the heart can be recorded in the form of electrocardiogram, ECG, or EKG. An ECG is a
Now, for right now, you don't need to know the waves, but you could see how the P wave signals the beginning of the contraction of your atrium, because your muscle, your heart is a muscle. So, and what makes muscles contract or get smaller, or in the case of the heart, pump? Electricity. So you could see it doesn't take much electricity for the atria to pump. But if you look at this QRS complex, and a complex is a combination of three waves, Q, the R, the S, it's huge. And that makes the ventricle. And then the T wave is like the reset button so that you can start this process all over again.
Composite recording of all the action potentials produced by the nodes and the cells of the myocardium. Each wave or segment of the ECG corresponds to a certain event of the cardiac electrical cycle. When the atria are full of blood, the SA node fires, electrical signals spread throughout the atria and cause them to depolarize. This is represented by the P wave on the ECG. Atrial contraction, or atrial systole, starts about 100 milliseconds after the P wave begins. The PQ segment represents the time the signals travel from the SA node to the AV node. The QRS complex marks the firing of the AV node and represents ventricular depolarization. Q wave corresponds to depolarization of the interventricular septum. R wave is produced by depolarization of the main mass of the ventricles. S wave represents the last phase of ventricular depolarization at the base of the heart. Atrial repolarization also occurs during this time, but the signal is obscured by the large QRS complex. The ST segment reflects the plateau in the myocardial action potential. This is when the ventricles contract and pump blood.
Now, remember we talked about the ventricles? Now, again, these waves won't be on your exam, but it'll help you understand the electrical conductivity of the heart. But definitely, you'll be tested on what are the parts and what's the order of the electrical signal. And I'll show you a picture momentarily. But did you see what he just said about the ST segment? The ST segment is the height of contraction of the ventricles. That's why when you get a heart attack, you're going to have STT changes, because that makes sense, because that's when the ventricles is it's the height of it's the height of contraction. And if you have a myocardial infarction where a part of this left ventricle is dead, it's going to show weirdness here. And in the form of, just academically, so you know a little bit about, little preview about your EKG, you're going to have segment elevation or depression. And you're also going to have what they call T-wave inversion. This T-wave won't be up, it'll be upside down. So STT changes are classic EKG sign, because it's an objective piece of data, right? Symptom is what the patient feels. Sign is actual thing we could see. We can actually see and like, oh, hey, you either are having a heart attack or had a heart attack. 2 terms ago, I actually, the class actually diagnosed a previous heart attack in one of my students. She's diabetic and she didn't even know she had a heart attack. And in my EKG class, we do EKGs on each other to practice on real life human beings, because that's the best way to do it. And then the student says, Dr. Garais, there's something wrong with the EKG machine. It goes, it's printing the S, it goes, the ST segment and the T wave funny. And then when I looked at it, I'm like, oh, and then I asked the student, did she have any chest pain? And all she said to me was, yeah, I had some like bad indigestion a week ago. And all I told her was, don't freak out. You probably had a heart attack, which, by the way, fast forward, she didn't. She went to go see her doctor because she's diabetic. She had what they call a silent MI, or a silent myocardial infarction. Because remember, when you're diabetic, your nerves get affected by the massive amounts of sugar in your system. Sugar will then interfere with the conduction of signals to your brain, and it'll even forget to tell you or block the signals that, hey, you're having chest pain.
The T wave represents ventricular repolarization immediately before ventricular relaxation, or ventricular diastole. The cycle repeats itself with every heartbeat.
Okay. You have to find that amazing, because that's been going on since around week 6, week 8, when you were inside your mom's uterus. And of course, I will make this video available also in announcements. All right. What else? Let's look at an actual diagram, an actual picture of the conduction system of the heart. Even though it's mislabeled green, it should be labeled yellow. What do you need to know? I need to know where my SA node is. And you could see it's in the superior portion of the right atrium, right? Right in front of the door of the superior vena cava. Then you have your AV node, right? Then you have your, this is not a very good, let's try a better picture. Here's a better picture. I really should get a Pinterest account, because I keep on, all right. Now, typically, they would call this yellow because nerves are full of fat. So what a node is actually just a bundle of nerves. So the SA node is your pacemaker. It's located in the right atrium, right at the door of your superior vena cava. Then right on your atrial wall right here of your right atrium, you have your AV node. So that's your pacemaker, and this is your brakes or your gateway. Right here within the interventricular septum is your bundle of His, which then breaks off into your left and right bundle branches, and then ends up here all throughout the walls of the ventricle as your Purkinje fibers. So what could you do? You could take a picture like this. I could take all of this out. A, B, C, D, E, F, G. Which one is the brakes or gateway? Which one is the pacemaker? Goes, which one is the bundle of His? Which one is, it's very easy. It's straight up anatomy and straight up quick points. So you could see now, if I put this diagram, it's easy points. And also it's things that you need to know clinically. So when you look at EKG, you know what you're talking about. And you look at signs and symptoms, both cardiac and pulmonary, then you know of which you speak. And isn't that why we're all here? So with that, that concludes the box diagram and the week 6 lecture. There's other things there that's nice to know, but these are the week 6 stuff, MED110, that need to know. You need to get all of this that I just talked about in your skull. Okay? All right, everybody. Thanks for playing, and I will see you next week or in lab.